morning, so we'll call our Finance Committee meeting to order, October 29th. We have our agenda in front of us. Are there any roll call? Yeah.
Dr. Gallagher?
Here.
Julie Peterson? Here. Matt Cofranzi?
Here.
Jessica Dixon? Here. And Chair Burns?
Yep. Do we have any changes to the agenda as mailed out on Friday? No changes. Any public comments? Any comments from the room? Online, do we have any?
No hands online.
Thank you. Any comments from committee members? No comments. All right. We have our consent agenda. Our minutes from our September 24th meeting were included in the packet and on consent. Although I was absent, I have read and assured myself of understand the meeting, so I see no reason to edits or changes. Do we have questions, comments on the consent agenda? Any public comments on? Any comments from the board members? None. Do we have a motion to approve the consent agenda, including the minutes of September 24th? Thank you, Matko. Do we have a second? Thank you.
Director Gallagher?
Yes.
Julie Peterson? Yes. Matt Cofranzi?
Yes.
Jessica Dixon?
Yes. So item number 2 is our financial performance for September 2024. Julie?
There we go. Yes. Go ahead. All right, Julie, give me one. Well, month of September, we had a strong month. We had, a number of kind of one-time items and things that happened in September, so definitely led to a higher than normal net operating revenue. Some of the big one-time ticket items, we processed the Packard loan payment of $500,000, so we get to recognize that as revenue. We had about $760,000 worth of alliance incentives. We had a QUAF pledge refund of about $240,000. We also, continue our work with AR valuation and bad debt improvements, and so while those kind of have more of a year-to-date impact, we did record some of that in September. And then I think, expenses were generally pretty normal. We were able to refund or get reimbursed for some of our bond expenses, the bond sale expenses. The majority hit, so they were kind of split between the district and the hospital. The hospital was more around staffing. The district was the election fees and some legal fees that we were able to be reimbursed. And that was about $250,000 in total. So as you can see, we ended up with a very strong month for September at $2.5 million worth of income. Next slide. So the best news of this is that on a year-to-date basis, we have a positive net income of $1.2 million. Really nothing else exciting to share there, because most of it was in the monthly stuff. Admissions, it was kind of a normal month, 268 admissions, so a little bit lower, definitely lower than August, and kind of in the middle of the pack for what we've seen throughout the year. Next slide. This is the kind of admissions and observations combined look, and observations were down a little bit this month, and in total, this September as compared to last September was 26 total less than last September. So from a seasonality perspective, pretty similar. Next slide, I changed this up a little bit. This is your average daily census is the line, and the green bars are the average outpatient visits per day. So as we've talked about, census has been on a bit of a downward trajectory. It's starting to soften up a little bit as we've got more months where we are doing the proper medical necessity check between inpatient and observation. That downward decline is a little flatter. And then it's probably also a little less of a increasing slope on the outpatient visits. Definitely still seeing it. We definitely had strong outpatient visits for the month of September. And so those line up with what we've been. But here's breaking down the outpatient visits per day. I decided to change this up a little bit too, rather than doing the stacked graph, just to show a little bit more about the trends. So the blue is your ER visits per day, and that's really fairly flat. I mean, for the month we were at 92.5 ER visits per day. That's not including admissions, which usually adds 4 or 5 a day. The green bar is your outpatient, non-emergency room outpatient, and we were at about 121 for the per day for the month of September. And that one has been decreasing. A lot of that is, can be somewhat dependent on the imaging area and the staffing challenges and or equipment challenges that we see throughout the year. That is usually one of the biggest indicators of some of the variation that we see over months.
What's the footnote?
Oh, it just says whenever we have an ER patient who converts to an inpatient and becomes an admission, these numbers are not included in ER visits.
Would that include somebody that spends time in ER, seen in ER, and then admitted?
Yes.
Okay.
Yeah. Next slide. Deliveries, it was kind of a normal month there. We've been averaging, a little less than, or low 60s, and we were at 57 this month. By total surgeries, so green bars being the outpatient surgeries, we had 124 this month. Not green, blue, sorry. The green bars, we had 62 inpatient. And the purple line is our robotics cases. We have robotic cases. The same trends we've been seeing. From a payer mix perspective, a little less favorable payer mix this month compared to last month. We were down a bit in commercial, about 2% down in commercial, about 4% up in our managed Medi-Cal. Medicare was flat, and a little bit of movement between the straight Medi-Cal being a little higher and managed Medicare being a little lower. And we were down in the self-pay. On the outpatient side, it too was a little less favorable. We were down about 1.5% on the commercial mix, and we were down about probably about 1.7% on the Medicare mix. Most of the increase was in the Alliance, up at 48.6% for the managed Medi-Cal. Everything else fairly flat. So, the good news is we had a strong month financially, a strong quarter, helped us achieve all of our goals. And now as we, work into this last quarter of the year, we're budgeted for a slight loss, although I think just, the financial success that we've had this year, if our volumes hold strong and we can, not have any kind of unforeseen circumstances, I think we could do a little bit better than what we budgeted and we have a strong year end. Questions on the financials?
On 2 slides back, you talked about the decline in commercial payer mix. It looked like both of them are bigger declines for the last couple of months than where we've been over the prior 10 months. Is there anything other than seasonality attributed to that? Is where we for providers?
It's not really. It isn't really. We were at 16.8% commercial on the inpatient mix. A couple months ago, we were at 13.7, 14.3, 15.8. It's just we were better in August. So that's the blue up at the top there. Might be easier.
I was in the wrong blue.
Yeah, that's the Medicare.
At the bottom of Medicare.
Yeah. And we've seen, a little bit higher managed Medicare. I think time will tell because I know, United Healthcare pulled the canopy plan for next year, so, there's not a lot of managed Medicare plans in the area.
Any other questions? Any questions on financials? No. Move on to our next discussion item, is the 2025 budget update.
Okay. So this is a lot of numbers. Don't get too glued to the numbers themselves because they're still all kind of moving. I think that this budget presentation is going to give you a flavor for where we're at, but there's still a lot of moving parts and pieces here. And as we kind of try to refine some of our modeling and make sure that we're remembering everything that we're hearing about and that's kind of in flux, the numbers themselves will change. So I kind of broke it down just so that the print wouldn't be too fine a print on the online. Let's start with the revenue side, giving you a little bit more detail than I've given in the past to give you a flavor, but it'll be more meaningful when I talk about some of the comments on the next slide. But here you can see we're budgeting a total gross patient revenue 1.122, so 1.1 billion, slightly less than the current year where we're kind of annualizing after 9 months that we're going to land, and I'll explain that in a minute. We've got our deductions, both our DISH and our QAF payments are estimates. We know about QAF 8, but QAF 9 is not yet approved, probably it's not even kind of rolled out. There's rumors that it can be better as they move to the more of the directed payments, but it's also probably not going to know of any approvals till like mid-year. So to be conservative, where we kind of knew what QAF 8 was going to do through the first half of the year and even into the third quarter, we kind of looked at what is QAF 8 doing this year for the fourth quarter, and we used those numbers, even though they hopefully will improve. So we may be a little bit conservative on the QAF payment. That we had that happen this year, and of course what happened was the QAF expense was higher than we budgeted, but the QAF revenue was even higher. So, we still won on that one. Bad debt, we have been doing a lot of work in bad debt, so we are budgeting a slight decline, and that is still up to, a little bit of refinement. And so right now, the net revenue, and what I call base is before initiatives, we're being conservative and saying, we should land at least where we're landing now, and I hope I'm being overly conservative here. We did back out some of the things in other revenue because there was a lot of one-time items that we don't expect to happen next year. And so you'll see that the net revenue here is actually a bit lower than where we're anticipating finishing this year.
Relieved that this team is going down 23 to 25, is that nature of 2023 being artificially higher than usual, or is there something
The
underlying?
dish payments have been, on the potential chopping block for a while, and every year there's like a rumor that they're gonna be reduced. They could be half of this 1.6 million for next year. It always seems to, kind of get to the 11th hour, and then the reduction gets pushed out. So this was our kind of best estimate without assuming a 50% reduction from our vendor that helps us with payments. Next slide. So here's a little bit more insight into the revenue piece. The reason that you saw the gross revenue going down is we did another CDM change. Overall, we have a decrease of about 2.3%. We do have strategic increases in different hospital service categories, but we also have some decreases where when we looked at what we were charging versus what we were actually getting paid and what our competitors were charging, there wasn't, a lot of rationale for keeping the pricing high as it was. We weren't getting paid, so all that was just going straight to the deduct line. So we are strategic in how we looked at where's the volume, where's our best chance of improved reimbursement, and also how do we line up with our local competitors. As we've talked before, generally speaking, our volume increases are 1% in admissions and about 2% in the emergency room, 2.5% in the other outpatient modalities. Like I mentioned, we've kind of estimated QAF and DISH, trying to be somewhat conservative and keeping our fingers crossed that DISH doesn't actually get further reduced. And the part of the slight reduction in the bad debt is we've done a lot of digging in our self-pay. We're working with our current early out vendor, Elevate, in terms of how we value true self-pay versus self-pay after insurance and what the kind of collectability has been, what their experience has been. We've also brought on a new bad debt collections vendor, so went from having no vendor take the AR and try to work it after it came back from the early out vendor to having a vendor now work it. We're only a couple months into that. I have not yet met with them to see any reports, but I know they've collected some, and I think with now that we have a process feeding them accounts every week, that we'll see some collections there. Next slide. So on the expense side, generally you can see this is base only, so no initiatives in here. This one's almost, I'll leave the slide up and talk to the next slide from here, so I remind myself of the notes. One key thing is there's one less day in 2025, and some of these numbers come straight off of, kind of an expense per unit of service type calculation. We also have our inflationary factors that we've talked about before, ranging between 2.5% to about 4%. In some of the cases, and especially in labor, we've been doing more detailed work at labor standards. We've worked with nursing on their staffing grids and identifying what their staffing should be given whatever census point they're at. And as always, whenever you have volume, that generally tends to increase your efficiency, and that certainly is the case in our nursing units. All of these expenses, these numbers, in my mind, they're directionally correct, but they'll all shift as we continue to refine some of the calculations and really drill them out to the department. And then I was going to do something with property, the whole property purchase, and there's so many moving kind of parts and pieces about what that looks like post-sale, that for now, I just left it in as we run it. And in next year, in the next iteration, when we come back in November, I'm hoping to have kind of more clarity about how we're going to book that. So we currently have in here, kind of the insurance as we've been paying it through MPT for the property, as well as the lease payment and the kind of amortized interest that goes with the lease payment. And some of that's in the bottom line. You can skip a slide because that's everything I just said. So here's what, when you kind of pull it all back together, again, highlighting that we've pulled out some of the net operating revenue that was one time. We've still got a lot of work to kind of finish reviewing expenses, and we haven't done anything with the property purchase and insurance piece. This tells you that, basically with a little less revenue and adding inflation, we have a slightly negative EBITDA and kind of the same loss we're accustomed to with the full MPT piece in. Next slide. So here's where we start to talk about initiatives, and we're trying to build out each initiative and validate our thought process behind it, what we're using as kind of source data when it's going to be a best estimate to get there, and pro formas where we have them. So all of these calculations still under review. We are trying, when we do these calculations, again, much like we do in the base, looking at when will we gain an efficiency by maybe having some more volume, and also, we continue our work with the GPO. We've finally started getting reports. We're still really kind of trying to understand what they're telling us from Vizient, so we can I've made basically an estimate of savings now, and hoping to refine that. And then this didn't quite get there. We do have some other initiatives where we just haven't put the math behind them yet. And, my gut says this just didn't quite get me where I wanted to be. So, my last bullet point here, I'm going to look for another $500,000 or so in initiatives because I'm shooting for that $5 million EBITDA target, but also, I say that. I was doing this last late at night. I think part of it was I know a few of the things that I still have to put in have costs associated with them, so I think I was thinking it was going to drag up below the 5.2 I'm showing now, and I want to make sure I get back there, or have a good reason not to if we're a little further into this. So what we've got on here, we've got the cath lab. We've done a pro forma on the cath lab, given volumes that our physicians have, estimated putting it into a, kind of a ramp up, assuming that we're going to open this cath lab early in the first quarter. And so if those things all play out, we might get a slight bit of net income from that. The pediatric volume, there's, been discussions that that we might be able to get volume from some of our local competitors that are kind of looking to move volume, maybe not support a program. So we've done some estimates of what that could look like. The improved collection efforts, there's so much work that we're doing there, and I think it ties to our revenue cycle improvements around how we're getting self-pay patients qualified for Medi-Cal. There's how we're working some of the aged AR. There's how we're valuing some of the different payers. We're just continuing to do a deeper dive. I've been working with Guidehouse on our whole AR valuation process, and Jessica's been working this one every month for many months. So this is just the almost $2.5 million really reflects about 0.25% improvement. So it looks like a bigger dollar, but you know, this is basically about a lot of little things that could drive some better revenues. The labor and productivity is premium pay, so overtime, double time. Right now, this is kind of a placeholder. It's about a 5%, 0.5%. Where did I go? Now I'm going to remember. It would be about a 0.5% improvement, or I think I went 0.75% improvement. Just looking at what the current salaries and wages piece looked like. I didn't want to put too much energy into it until I further refined what the true dollars going in were. But, you know, I know last year we were in about $1 million range, and we've made some improvements. We have some kind of added staffing as like Phyllis has worked on her standards of care and where there were some holes. So, you know, I'm thinking it's probably somewhere in the ballpark. The supply expense in GPO, this is about 5 or 10% improvement there. Forget exactly which number I went with, but again, refining it, having some of the data we've looked at has suggested we have opportunities for better tier pricing and to optimize some of our, you know, which vendors we use. And with all of that, you take the big list and then you know, kind of look at which ones are probable and which ones are less likely or more likely to take longer, kind of, you know, discount the savings there. Dr. Ravigo, this is on the clinic side, bringing his primary care practice in, and this is based on a pro forma that was put together about bringing his practice over. LED light replacement is you know, estimated to bring us a $90,000 savings on electricity. The Kaiser Salinas volume, they've given us some estimates of volume they'll bring both in surgeries, deliveries, and so we've done some estimates just based on kind of our current mix of Kaiser volume. So that's what we have so far.
Ask about the Ravigo.
Mm-hmm.
Is that a new provider or no? The existing practice?
It includes some work towards bringing in some new providers, but I forget exactly the timing on that. I think we had that in year one to try to bring on like an NP or yeah. So some of that would include new provider costs. I think that was my last slide.
Just to follow up on the new practice, is that a net of revenues, the revenue brings and the cost, it's a net $300,000 or so?
Primary care in Northern California did nothing.
Yeah.
We're not anticipating those benefits of the hospital, correct?
Right.
Correct.
Yeah. I don't think there's no kind of ancillary
Downstream
revenue.
would be a bonus, right?
Yeah.
That's certainly something we would count on.
Yep.
We would hope that would happen, but not guaranteed.
Sorry, go ahead.
So my thought is, having been a primary care doctor, we're not out going to, turn whatever. People take salaries, people have fancy cars. And so I'm a little bit surprised that Dr. Ravigo is in the overheads are high. I mean, mine used to run 65%-ish. Still people. Are we sure we put that closely enough? these aren't his numbers, because these are ours, yeah. Okay. Yeah, and again, we do this because we want to feel like growing primary care and growing as a sort of a multi-specialty group in coastal healthcare is the right thing to do for our district, and that financially, in the long term, it's a beneficial thing because it allows commercial patients who live here in this area to have care within our healthcare family, and that those are referred for ancillary and specialty care within our healthcare family and at the hospital. But this particular analysis doesn't factor that piece in, so that would be, I agree with all that. If you ask the other healthcare entities in Northern California, they're not making money on primary care. Just talked with, I was just part of a roundtable yesterday with Jimmy Panetta, a bunch of local doctors and healthcare leaders in Santa Cruz County, and they were all talking about how Medicare doesn't pay enough for primary care, losing money. Yeah. So it's an important investment.
Well, coming back to the big picture on these 2025 initiatives, these are not included in the previous slides. These would improve the outlook for next year and how we get to our target, 5 million or so. Are any of these on this list a risk factor right now to include them in the budget? Are we feeling cath lab, pediatric volume, are we feeling reasonably confident that these are reachable goals for 2020?
For the most part, I think these are reachable. The pediatric volume one, we had some earlier estimates. I actually cut it in half from our earlier estimates because that is kind of a larger unknown, and we're, working ourselves in terms of kind of changing the way we have, care for pediatric patients so that we have more stable staffing, because it's been very hard to recruit those med-surg pediatric competent nurses. So, Phyllis has been working on a whole plan there. So of any of them that are listed here, that would be probably the least. Most of the rest of this stuff, the Kaiser volume, they gave us their volume estimates. That would be, I didn't think that their estimates were overly optimistic. They seemed reasonably conservative.
The question that's bigger than the LED light replacement. The question is, do we have a sense of what the amount of our deferred maintenance on what we haven't been investing over the last 20 years, what that number is? The napkin math, or we have it by asset. At some point, that would be helpful to have it part of this presentation, not today necessarily, but when we're talking to the public and we're talking forward, be able to say, yes, we're balanced, yes, we've got our profit, and yes, we still have these 20 years of deferred costs. Then the comment, I don't know if LED light replacement, that might fit, but certainly it's with our bond proceeds for projects. Definition of capital might allow for things like that, or other things. And then the real question is, going back in the budget, we had about 1.5 million in repair and maintenance, and I presume that's just purely the stuff we expect to fix, not just, we're still not doing some capital.
Right.
Yeah. Correct. Yeah, that's just your kind of run of the mill.
What we must do.
Repairs and maintenance. Yeah, I think the LED light replacement would not qualify as something we could get bonds on, but I know Max has looked into, ultimately solar and that sort of project, but.
Yep.
lot of roof space.
Getting to the bonds with construction, it's probably, I mean, thinking about the disruption to ER, patient care, reducing numbers, reducing revenue, depending on how good we set up alternate. Yeah. From a timing perspective, are we still thinking 2026, 2027? And this is my memory of remembering, was it 2026, 27?
Yeah, I think
So
we're
we're-
working on development of
Yeah.
the line for next year.
Yeah.
And then go forward.
So the 2025 budget should have a risk factor to patient disruption.
Correct.
Yeah.
And our plan, even with the expansion, would be to minimize disruption, continue full operation.
Yeah.
during that.
And are there any within a line, are there any design consulting costs that we've included in the budget? And that should be a net negative to get reimbursable. We haven't functionally in the budget yet, or is there still something more working on?
It's not in the budget.
Okay. Channeling fellow chair, or board member, fellow board member and chair, yes, marketing, what, are we status quo with investment in marketing and outreach?
We've got $100,000 in here for marketing, which is what we had told Nancy she could have last year, but I've told her this year she can't spend it, so. Yeah, so that in the budget doesn't mean you can spend it, so she's spent a much smaller amount than that this year, but $100,000 for now.
And, salaries and wages based on number of FTEs, do you have any areas of growth in FTE counts, whether it's providers or practitioners or?
Yeah, we're not, projecting growth in FTEs. I mean, we may get a little bit
Yep.
here and there, and that some of that may come out in the refinement, but generally, in looking at the volume increases we've projected and the efficiency needs that we have and some of the, work that's been done on staffing grids and things like that, we are projecting to, do this amount of volume with the staffing level.
Final question I have is, as far as timing, over, we'll be reviewing this with the board tomorrow. Are we on, feel like we're on cue to, when might we be bringing it to the board to adopt the budget? December meeting, or are we still December?
Yeah, well, my goal was to have this thing buttoned up by November.
Yeah.
We've had a few snags along the way, so I'm gonna still push for November, knowing that, taking it to the board in December is an option, but not one I prefer.
Our meeting earlier this year with November.
Yeah, same in December, yeah.
Yeah.
So, I think, at some point we'll get to the, we could analyze this for another 6 months. So you'll have to just get to that point of going, this seems the most reasonable approach. And I think that's really kind of at the point I'm at now and working with, Vanessa and Ivory and stuff is, and the, leaders that have been involved, people giving me inputs like Matco and Phyllis and things, is just kind of when do we say, okay, this feels reasonable, let's go with that. And we're trying to really always document our rationale and what our thought process was, so that at least if we have a variance, we can kind of go back to, try to explain where things changed from what we were thinking.
I'm gonna say last, I have one more kind of big picture question. It's one of that, before that advocacy happened, how might the board play a role in helping with their budget? Form of reimbursement rates, Medicare free. Is are there other spaces that in the last couple months are working the budget you guys thought about that the board might be helpful in advocacy efforts, ultimately could help improve our bottom line?
Well, you know, we're
Grant
still
capital,
trying to get the HCI, loan forgiven. We did talk to them, you know, a few weeks back, and, you know, they're definitely looking at some kind of loan forgiveness program, but they hadn't put together the guts of it yet, and they anticipated January, February, we would maybe start to see what the criteria were so we could apply for loan forgiveness.
Yep.
So that would help. You know, really, everything at this point is more about things that help us generate cash. That is such the challenge because, you know, the supply costs and the staffing costs keep coming, have their inflationary or their union-based increases, and so we've got to build that cash faster than those are growing.
Still concerning the agency our size and critical care with the cash balance we have. Looks like it's a petty balance.
Don't look at it daily like I do. You start jingling your pockets.
I appreciate all the effort, quite that challenge. That's a great, or you guys have 15 working on that. Don't leave. We'll be fine. No, it's highlighted by having a good month on the books, but the cash balance position necessarily move up that much because a lot of this book revenue, not necessarily cash revenue.
Yeah.
Yeah.
Not an easy thing to describe sometimes.
Yeah.
Internal and external stakeholders.
Yeah. It is when you show them the cash balance in your bank statement. Come on. So any
No.
board members? Anything else?
It.
Wrap up the session?
Maybe before you make the final, what would be expected cash balance?
You know, I would say we should have a 30% reserve cash balance, so if you're talking about a $100 million annual budget or $150 million, talking $30 million at least. Because you want emergency, you want this cash pile, you want, this went wrong pile, and then you want like just steady little cash flow operation, and you always want other cash on hand, so we'll be at $6 million, that's the number, so.
I think nonprofit hospital average is like 150 days of cash on hand, and best practice is like 212. Thanks for the perspective. Got a ways to go.
Those are the bold numbers.
They are.
Yeah. Any questions, comments from online?
Nothing online.
All right, we'll conclude that discussion item and adjourn our meeting.
Thank you.